So I'd like to introduce myself. So for those of you who do not know, my name is John Cole. I'm a historian who's been working with the Tuberculosis Program Evaluation and Research Unit at the University of Alberta. And there for the last 3 years, and maybe even a little bit more, how the time flies, I've been studying the history of tuberculosis in Treaty 8 territory. And more recently, this research has been a part of what we've been calling a digital knowledge exchange on the history of tuberculosis in Treaty 8 territory. And we've created a digital platform through which you can share and access stories from people with experiences with tuberculosis in Treaty 8 territory. And I'll share the link to that website in the comments when the presentation is over. Finally, I'd like to begin by acknowledging that this presentation is taking place in Treaty 7 territory, but the bulk of this research was conducted in Treaty 6 territory when I was living in Edmonton. And as the title suggests, the focus of the study is Treaty 8 territory. And I say that because it's very important for us to acknowledge the places that we occupy. And I think especially as we do or we make our connections increasingly over digital spaces, and especially as it relates to this digital knowledge exchange in this presentation, it's important to always be aware of our relationship to the places that we occupy. And place, indeed, is a central focus of this study. So place and the relationship to tuberculosis is something that is present in contemporary rates of tuberculosis. So there's a remarkable focality in the rates of TB in the Canadian-born populations. That is, Indigenous Canadians have, for as long as tuberculosis has been reported, experienced higher rates of disease than non-Indigenous born Canadians. Status First Nations and Métis in the provinces of Alberta, Saskatchewan, Manitoba, i.e. the prairies, contribute to more than half of the total Indigenous tuberculosis cases in Canada. Moreover, there is a focality of the disease that has recently been discovered in the prairies, with about 84% of pulmonary tuberculosis cases, those with the ability to transmit, occurring north of the 53rd parallel. And so this geographic focality suggests that place is an important factor in determining rates of tuberculosis. And so the focus of this presentation is one such focality in the southeast portion of Treaty 8 territory, along the Clearwater River and Athabasca rivers. So tuberculosis disease, TB, is found at the intersection between Mycobacterium tuberculosis, MTB, and a distinct constellation of social conditions in which this bacteria thrives. In short, particular conditions need to be present for endemic tuberculosis to occur. And these conditions can be loosely described as a place. Place is a complex object of study. That is, in part because they are constructed both materially and through imagination. For example, a place can be influenced by environmental conditions as well as through government policy. Not any one factor will create a place, and nor will any one thing create the conditions where endemic TB persists. And these factors are the result of purposeful action, whether the outcomes are intended or not. And a place can change or be manipulated through ecological or economic trends, such as those drastic changes which occurred in the 20th century. So I will begin by describing the history of tuberculosis, including the development of modern understandings of the disease that arose in the 20th century. Next, I will briefly cover general economic trends that contribute to contexts where tuberculosis thrives. And finally, I will cover the history of government tuberculosis programs in the southeast portion of Treaty 8 territory, or this yellow region that we see here highlighted on the map, the Clearwater and Athabasca rivers. It is important to note that each of these factors together create a place and none alone are contributing factors. Okay, so what is tuberculosis? In 1882, Robert Koch isolated Mycobacterium tuberculosis, MTB, and established the etiology of tuberculosis disease. TB spreads through the air, and when MTB is aerialized, through coughing or sneezing. Inhalation of a single bacterium into the lungs of a susceptible contact can lead to the establishment of an infection. But exposure to MTB alone does not usually result in disease. Disease takes time to develop, with a transitive state between infection and active disease. When TB occurs, it is generally in specific environments where the organism can easily be transmitted to susceptible contacts. And so we can think about these environmental contacts or contexts as a specific place or the construction of a specific place. Malnutrition, for example, dramatically affects cell-mediated immunity, which is the principal host defense against TB. Likewise, overcrowding of living spaces facilitates aerosol transfer between people. Both malnutrition and overcrowding stem from socioeconomic disadvantage. But with that in mind, material conditions are not the only factors which contribute to TB. Indeed, discursive factors also influence the presence of disease. Tuberculosis may be further exacerbated by delayed diagnosis of infectious cases and prolonged exposure of contacts. Two factors directly relating to program policies, especially surveillance. There are scientific arguments that tuberculosis is a bacteria native to North America. That said, the prehistoric origin of MTB is not as significant as the networks of transmission and the imposition of systems and structures which allow for tuberculosis to persist. Present-day genome sequencing suggests that tuberculosis found in Métis DNA people today share similar genetic signatures with the TB found in Quebec. And the assessment of this is that these strains of tuberculosis moved along trade routes, creating reservoirs of latent TB around trade posts and other areas of congregation. A 2018 study found that strains of MTB within First Nations communities in Southeast Treaty 8 territory were endemic, further suggesting that the same bacteria has persisted within the same communities for a long duration of time. That said, evidence of MTB alone does not constitute a health crisis. Tuberculosis rates are the highest at the intersection between the biological organism, MTB, and the social economic factors in which tuberculosis thrives. And it is with this in mind that we need to focus on the human artifacts that contribute to TB. That is, the factors that constitute a place. The relationship between the British North American government and Indigenous peoples in the Clearwater River and Athabasca region predates Confederation in 1867. The economic relationship between fur trade companies and First Nations motivated Western expansion into North America. And the Clearwater River and Athabasca River were some of the most fur-rich regions on the continent. And as early as 1872, fur traders grafted their posts onto local trade networks in hopes of achieving a profit. The socioeconomic ramifications of this early trade in the 19th century was not entirely disruptive. Trade was a supplement to Dene and Métis economies. Bands were able to maintain time-honored subsistence cycles that included traveling long distances for hunting, trading, and for marriage. And indeed, the fur trade economy remained relatively prosperous into the 1920s. However, thereafter, and especially in the 1930s, the global fur market collapsed, creating an economic crisis. Health in the Athabasca and Clearwater River districts was cyclical. Prosperity and health reflected economic trends. It was an economy that depended on returns from the environment, and the availability of plants and animals ebbed and flowed based on yearly conditions. During periods, the profits from the trade were plentiful, but conversely, if hunting and trapping failed, it resulted in lean times and poor health. Where we see the most drastic changes occurring is not until the 20th century, and especially after 1899 and the signing of Treaty 8. Although the process of colonialism was slow to develop in this region, the conditions that arose in the southern portions of Treaty 8 territory began to develop much akin to those which had occurred in the southern portion. Including the economic crisis and the imposition of the residential school system and the reserve system. But we don't really see these developing immediately after Treaty 8 territory, but instead, immediately after signing the Treaty 8 in 1899, but instead we see it develop in the 1910s. And this especially occurs in 1912 and 13, 14, 15, 16, when a railway was under construction to Fort McMurray. And as such, freight work, which was the principal wage labor opportunity for First Nations and Métis outside of the fur trade, was in decline. Indeed, the railway proved to be a much more efficient method of bringing goods to the north. But along with bringing goods to the north, the development of a railway facilitated immigration from southern and eastern parts of the country into the Athabascan Clearwater region. And this was not exclusively those with the intent of living there, but it was also the advent of corporations rapidly staking claims around the Fort McMurray region. And this stressed hunting and trapping opportunities. So by 1916, in the face of increasing settler and corporate land claims, the Department of Indian Affairs finally began to survey reserves, which in turn created a social setting with poor sanitation and overcrowding. And so you see these material developments in place occurring, a decline in fur-bearing animals, as well as protein-based hunting or pot hunting, in conjunction with an increase of Euro-Canadian settlement and international corporate interests in the region. And along with this, these material changes was also the imposition of some structures. And I'm going to go over these very briefly. And that includes the residential school system in the early 20th century. And the residential schools, although I'm not going to go into too much more detail, were soaked in tuberculosis. And this is due to the combination of chronic stress, malnutrition, and overcrowding. In other words, the perfect context for active disease to develop. While these economic and social changes were not particularly unique to this region, the largest difference between here and the more southern and eastern parts of the country was the time at which they were occurring. The depletion of game and other economic opportunities, in addition to the imposition of colonial structures, occurred decades later than they had occurred in the south of Alberta and Saskatchewan. Developing instead of in the 1870s, 1880s, 1890s, as they had in the southern parts of the region, through the 1910s into the 1930s. And so these, what it creates is a lag in time where these conditions arise. The relationship between the conditions conducive to tuberculosis were well understood by 1920. Nevertheless, contemporary data on tuberculosis in the southeast of Treaty 8 territory does not exist. And to understand this, we must analyze the development of tuberculosis programming in Canada, specifically that of surveillance. public health technologies and programming and their strategies for TB control affect the rate of tuberculosis. In the 20th century, tuberculosis programming was able to reduce the rates of TB because, in short, TB is a curable disease. And since the development of anti-tuberculosis drugs in the 1950s, tuberculosis programs were able to nearly eliminate tuberculosis in certain populations. Not all populations, but certain populations. Concerns surrounding the viability of contemporary medical practices, that is, medical practices prior to 1950, can be addressed by focusing on systematic deficiencies within medical systems. That is, concentrating on particular components that are not sufficient, rather than debating the legitimacy of historical medical practices. In this sense, surveillance is a meaningful and direct way to assess programming because it is a necessary first step to implementing treatment, whether that treatment was effective or not. TB surveillance is the systematic collection, analysis, and interpretation of health data. And surveillance is the most effective when it is integrated with timely dissemination of this information to allow those who can apply this information to make informed interventions. And so with this in mind, surveillance can be considered the basis for developing public health programs. It is a necessary first step. And the importance of tuberculosis, or of importance of quality tuberculosis statistics, was something that was well understood by public health officials by the end of the 19th century. The earliest TB population statistics in Canada were collected in the late 19th century in urban centers. Montreal and Toronto specifically began to track TB mortality in 1880. And in 1901, the Canadian Tuberculosis Association began tracking national TB deaths to the best of their ability. That being said, explicit federal involvement in tuberculosis prevention and treatment did not manifest until 1905. And so 1905 is when we really begin to see these federal efforts towards TB treatment. So how was surveillance conducted? Prior to 1907 and the improved tuberculokin test, surveillance in settler society was most commonly practiced through observation of patients by physicians. That is, by observing notable features of TB, including rapid weight loss and sputum-producing cough, and this made the disease traceable to an extent. However, tuberculokin tests were an especially powerful tool as it would expose those who were sick without visible symptoms. And by the late 1920s, this was supplemented by a system of chest x-rays able to look for presentations of cavities within the lungs produced by tuberculosis bacteria. The earliest nationwide effort for TB surveillance in Indigenous populations was conducted in 1908. And the Department of Indian Affairs sent a circular requesting a complete return of actual TB numbers across all Indian agencies. But spatial location shaped how this request was acted upon. For example, no such report was submitted for most of Treaty 8 territory, including those communities living in the Athabasca and Clearwater River. Now, our principal reason for this omission was that government structures were yet to be developed in this region. The Clearwater River Reserve, for example, was not surveyed until 1915, and the Janvier Reserve was not finally surveyed until 1922. Nevertheless, geographical challenges were expressed explicitly, especially the difficulty with which the Department of Indian Affairs saw accessing these communities to be. And this is reflected again in the 1920s when a new era of TB surveillance began. In the 1920s, there was a concentrated effort across Canada to find active cases of TB. And this was performed in conjunction with changes in 2 Canadian laws, making tuberculosis a nationally reported disease. And these surveys, as this picture suggests, was conducted through Canadian school children. In 1921, a royal commission was appointed in Saskatchewan to investigate the extent of tuberculosis, and it included a survey of 1,346 school children. So in all, 1,184 settler children and 162 Indigenous children were examined. In 1924, a similar survey was conducted in Alberta. In total, 1,136 children were examined for TB, but only 85 of whom were selected from the Indian Industrial School near Edmonton. And so here we see a picture of those exams occurring in Edmonton. But there were other broad surveys in the 1920s as well. In 1926, there was a TB survey conducted in British Columbia focusing on Indigenous peoples, and this survey included a total of 1,871 First Nations in a total of 39 communities. That being said, the only survey from the 1920s that I could find conducted in Treaty 8 territory was conducted in 1922 by Wabasca Lake. And for those of you who do not know, Wabasca is some 100 miles southwest of Fort McMurray as the crow flies. Differently if you take the highway these days, and most certainly much further if you were to travel by the Athabasca River. The principal purpose of this excursion was to vaccinate for smallpox. So this Treaty 8 surveillance was not indeed intended to be a surveillance of tuberculosis, but instead it was for inoculating for smallpox. Nevertheless, W.W. Bell, the physician in question, reported on the other health concerns, stating that almost everyone whom I observed while vaccinated appeared to have pulmonary tuberculosis. Likewise, of those 1920 surveys, there was found to be an alarming rates of tuberculosis in First Nations children, especially in contrast to those of Euro-Canadian descent. The geographical challenges of surveillance were well understood. In the 1924 meeting of the Canadian Tuberculosis Association, it was reported, and I'm quoting directly here, "We can easily see why it is almost impossible for the department physicians, most of whom are employed for part-time only, to spend their time specializing in tuberculosis or assembling statistics on the subject. The conditions are so variable throughout Canada that it is difficult to get any complete information, and there is growing anxiety in regards to this phase of work." Again, geography is a common trend, or the spatial location of these communities is a common trend. And this notion was incorporated in Treaty 8 negotiations. So here on the screen, we have an excerpt from the 1899 Treaty 8 Commission report, and it states, "We promise that supplies of medicine could be put in the charge of persons selected by the government at different points and would be distributed free to those Indians who might require them. We explained that it would be practically impossible for the government to arrange for regular medical attendance upon Indians so widely scattered over such an extensive territory. We assured them, however, that the government would always ready avail itself at any opportunity of affording medical services, just as provided that physicians attached to the commission should give free attendance to all those whom he might find in need of treatment as he passed through the country." And for the first decades after Treaty 8, the presence of Western medical professionals was almost entirely limited to annual treaty party visits. Yet even then, a doctor would not always accompany annuity payment trips. What resulted was a system of surveillance that was fragmentary at best. It was limited to the observation that occurred annually. And even still, this was not always the case. For example, in 1908, a medical officer would not join the trip. Notably, this is the same year that TB survey among all the Indian agencies was conducted across the country. In 1914, the Department of Indian Affairs reported that TB was more than a passing concern in Treaty 8 territory. The Department of Indian Affairs reports indicate that people around Fort Smith were experiencing high rates of active disease. However, the TB rates at Fort McMurray and Portage la Loche continued to be ignored in government reports on health. The same report assessed that a visit from a physician in the Athabasca and Clearwater region were infrequent, since the itinerary of the doctor employed to serve Treaty 8 covered a distance of 1,320 miles. The report quotes, or a quote from the report states, "The work is too much for Dr. McDonald to look after alone, as in order to keep up the standard of health in any locality, it is necessary for the doctor to visit at least twice during the year." The Department of Indian Affairs proposed to attach TB surveillance to the residential school system. Nevertheless, a uniform policy for screening the health of students was slow to develop. Moreover, a formal policy for how student deaths should be investigated was never introduced until 1935. The TB surveillance program within the Beauval School makes an interesting case study. By 1911, it had never materialized. A letter from the school to the Department of Indian Affairs, in reply to requests to ensure that only healthy students were admitted, stated that no physician was available due to how remote the school was. The official response was this: "In reference to the examination of children at this school by a physician, I would point out to your lordship the words 'where practicable.' The department is aware that it is not practicable for you to have children examined before they are admitted." In the backdrop of all of this is a particular brand of rhetoric. And this rhetoric focused on the relationship between TB programs and the proximity of settler society to a community. Indeed, the presence of a large reservoir of active TB near a Euro-Canadian settlement was viewed as a real risk, and the transmission of this disease was viewed as a threat to settler society. And this is a notion that gets repeated continually, both through newspapers and as well through academic publications and Department of Indian Affairs reports, that the principal concern of tuberculosis within Indigenous communities was that it could spread to settler communities. With this in mind, the miserable state of TB-specific surveillance was directly related to the health concerns of a settler society. That is, if a community was not viewed as close to settler society, then tuberculosis survey was not seen as a primary concern. Over and above this was also financial concerns. We need to bear in mind that in the late 1920s and 1930s, there is a global economic crisis, the Great Depression, and this hits the prairie provinces especially hard. And this is reflected in tuberculosis surveillance. In 1934, the Department of Indian Affairs stated that it was not financially possible to extend the effort of treating TB or even to maintain the programming at its previous standards. Indeed, the Great Depression ground TB programming in the North to a halt, only to be revived in 1937 and the creation of the Advisory Committee for the Control and Prevention of Tuberculosis Among Indians. Unsurprisingly, the focus of this committee early on was financial challenges. Although optimistic about the state of TB in Alberta and Saskatchewan in 1937, by 1945 the committee asserted that, in contrast to the southern part of the province, the state of TB in Alberta, north of Edmonton, was severe. And once again, the geography or the spatial location was viewed as a principal challenge. The conclusion was to create a centralized hospital in Edmonton to serve the majority of the north. The fundamental assumption that First Nations in Treaty 8 territory were too isolated for widespread tuberculosis program mirrored the language of the Treaty Commission report. That, again, stated bans so widely scattered over such an extensive territory. That being said, the concept of isolation is one that is pertinent to discussions surrounding healthcare delivery to First Nations. Mary Jane McCallum, in her analysis of medical writing in the Canadian Medical Association Journal, makes the argument that those who publish continually noted that isolation was a central contributor to poor health among Indigenous peoples. The Department of Indian Affairs' response to TB in northern communities was determined by its belief that some communities were too isolated to receive consistent health care. That being said, isolation is not a naturally occurring geographical phenomenon. Rather, isolation is a relative concept which is informed by power relations. The federal government chose locations for medical infrastructure that privileged some locations while ignoring others. The medical geographies of Canada were constructed in a way that some communities, such as those in the Athabasca and Clearwater River districts, were rendered isolated, thus dramatically impacting the quality of TB programs in these communities. However, it is notable that the regions surrounding La Loche and Fort McMurray were never too remote for economic development. Indeed, global corporations have been moving in and out of this region since the 18th century. Moreover, surveys for the economic potential of this region predate treaty and continued throughout the period in the 1920s and 1930s and well into the 1940s. Peoples are not unhealthy because of the places they live. The places they live were made to be unhealthy. Space and place are important factors in determining the quality of access to TB programs, and communities that were perceived as being isolated due to their proximity to settler centers received infrequent TB surveillance. And surveillance can be specifically understood as one of the initial steps towards TB care. The developments in the period before the 1940s is foundational to the creation of place and to the public health crisis which occurred in the southeast of Treaty 8 territory in the later half of the 20th century. It is with that in mind that I would like to remind you that this presentation was done as an extension of our digital knowledge exchange. I would like to direct your attention to it. I'm posting a link in the comment section for those of you who might be curious about this initiative. If you've got a story to share, or if you've got or if you would like to see other submissions, those from community members, you're more than welcome to view that website. And otherwise, at this time, I would like to point towards our funding. So here we've got a list of funding that would help contribute to this research, as well to the Digital Knowledge Exchange initiative.